endovascular first. Why not just do endo first? It's easier. If it doesn't work, then I'll do surgery.
Hello, I'm Mitchell Weinberg. I'm the Chair of Cardiology from Staten Island University Hospital of the Northwell Health System. I'm here with Dr. Matt Menard, one of the co-primary investigators for the BEST-CLI trial, and let's get to it.
So, at the end of it all, turns out that surgery was better for our primary endpoint. Our primary endpoint was different. The historic gold standard for a study like this would be amputation-free survival. We felt pretty strongly that that's not a very good endpoint if you're trying to really capture the impact of a given strategy. It kind of overplays death and underplays the specific consequences of a given strategy. So our endpoint was male-free survival, so major adverse limb event-free survival, and males made up of death or of a major amputation, a major reintervention. And so for male-free survival, surgery had a very clear benefit, had a relative risk reduction of about 30%. Couple of very interesting secondary findings. The death rate or the mortality rate for both arms was exactly the same. That's surprising to a lot of people. The MACE rate was identical between the two arms, and we had a whole series of secondary endpoints that we can talk about. But the main result in folks that were candidates for both, surgery was more effective at preventing a major adverse limb event and staying alive.
So, I'm a physician in the community. I have a patient with CLTI. Given the results of BEST, how am I treating people differently now?
Well, it's a great question, and the answer would be the following. One, the trial clearly indicated it's important to know the status of the vein, and so that's a bit of a paradigm shift if you're not a surgeon used to kind of assessing vein, but the trial would suggest that that's important to know the status of the vein before you make any decisions about which direction you might go. Obviously, this is appropriate to folks that you think would be a good candidate for surgery. We, as surgeons, rely heavily on your help in the cardiology and vascular medicine world to tell us that. But once you get that information, I would argue that the appropriate thing to do for a fully informed, evidence-based discussion is to talk about, we could do endo, we could do open, here are the results, here's the purported benefit. And, that's a discussion that has not always happened over the last number of years and decades. And so that would be a shift for some folks.
The results have been out for a bit now, and you've certainly been exposed to a good deal of discussion surrounding those results. Do you think that BEST-CLI has changed practice, is changing people's practices? And what barriers are there that you can see for the trial having its true necessary effect?
Yeah, great question, Mitch. So, I actually think it's too early to tell to what degree it's going to change practice. I hope it changes practice along with my co-PIs. If nothing else, I think it's generated a lot of discussion about, what's the best approach. As the background of this is an increasing kind of migration to endovascular first. Why not just do endo first? It's easier. If it doesn't work, then I'll do surgery. There's lots of data to suggest that, bridges are burned, or more importantly, outcomes after a primary intervention are not as good. So secondary intervention after a failed endovascular therapy are not as good. And so, I think strongly that it's important to kind of try to get it right up front. Endo is not going anywhere. So, if anything, I think hopefully it'll kind of foster the discussion of these are two different therapies. They're complementary. Really, really, really want to get away from one versus the other at the exclusion of the other. But, I do think there's also a buzz and a new enthusiasm and energy. This is one question amongst many, many, many questions that need to be answered for us to really know how best to take care of these really challenging patients. And I think there's a growing enthusiasm to kind of just look, do more research, do more trials, figure out the answers to so many unanswered questions that remain.
So you've done what is perceived by many to be a controversial trial and has created a buzz as you described. Do you see the trial results as bringing the many people involved in the care of the vascular patient together, of creating some divide? How do you perceive the reaction?
Well, way back when, the intent, the concept was, hey, let's just get a bunch of vascular surgeons that do both open and endo, and they'll do the trial. And there's no skin in the game. Don't care which way the result. NIH, to their absolute credit, felt that that was not a viable option, and if they were going to give a dime, it had to involve everyone. At the time, it was a North American trial, at least in America, that treated CLI should be part of this effort. And part of the trial, we mandated, so-called mandated CLI teams, where we wanted everyone that treated CLI at a given site to be involved, to be part of this team, a discussion, to pool the talents. I still think that's ideal. We had discussions or lectures this morning about that very topic and the benefits of teamwork and really kind of utilizing the entire expertise of a given institution. I think a lot of people would say, yeah, of course, that's a no-brainer. That should be done in reality. Lots of politics, lots of egos, all sorts of barriers to that happening. So in an ideal world, more of that. Will the trial, result in more of that? Time will tell. It's unclear kind of where the fields are going to go, in terms of CLTI care. There's certainly a lot of patients that need care, and really the focus should be on that as opposed to all the turf battles. But, good question.
This has been a tremendous amount of work for you and the other co-investigators and has taken years. One wonders what you're going to do now. Is there another NIH-sponsored trial in your horizon, another big endeavor, or are we going to sunny beaches? What's your plan?
Yeah. No sunny beaches, although that sounds pretty attractive. I'll tell you, I feel very fortunate to have been given a grant by the Novo Nordisk Foundation, a big foundation from Denmark. They've allowed us to do a couple things. They've allowed us to really do a comprehensive analysis and have the statistical support to really answer the questions, the many questions that the data, supports asking. So it's not just a very simple question that prompted the trial, but we have an enormous amount of data that we can now look at very closely. And, we have a lot of people. We had 1,000 investigators, and we have lots of people that are keen to dig into the data set. So we have the financial support to do, 40, 50, maybe even 70, 80 analyses that we're looking forward to. We didn't have the money, and we wanted to, but we didn't have the money, so we did not collect all the angiograms and all the imaging related to the trial. That's incredibly important to be able to tie the anatomic complexity of who was enrolled to the outcome. So another thing we're going to do is gather that, and also to do a cost-effectiveness analysis, really comprehensive cost-effectiveness analysis. The additional thing that Novo Nordisk Foundation has given us kind of permission to do and supported us is to gather about 25, 30 experts in CLI from around the country, around the world. We've had one meeting. We met in Copenhagen, and the whole goal is to try to look at CLTI from a global perspective, think about it, in the wake of BEST, in the wake of basal, in the wake of SweetPad 1 and 2 is coming down the pike, finally some real, data is being generated. What's the next set of trials that need to happen? Maybe some mixed trial with Xarelto plus endo, Xarelto plus open, more complicated next level trials. And look at health economics, who's doing what right in CLTI care around the globe, which country kind of has better outcomes and why, and how can we propagate that around the world. So really, to answer your question, excited to kind of think more broadly or more globally on CLTI and not just in the trenches of a clinical trial.
Great. Really interesting and useful. We have a ton of young investigators here at the SVM meeting this year. Given your experience, if you had to give them one piece of advice that would be useful to them going forward on creating a successful investigator career like you have, and really and make such an impact, what would that piece of advice be?
Great question. I think my answer would be, do not be swayed, do not be daunted by your own self-doubt or by the doubt of anyone around you. No one on the planet, including myself, including my PAs, thought we were going to get funded. Somehow we managed to convince people to give us the money. And, part and parcel of that is find a clinical question that you want to know the answer to, that you deeply believe in. And, that's where this came from. And, that's what powered us through it all. So, young people get that kind of advice all the time. Figure out what your love is. But in this case, figure out something relevant to your practice, your field, that you think would be useful to answer. Dive in. Who knows what will happen.
Matt, that was great. What an honor for us to hear you today speak at the session, and honor to have the conversation with you today. Thank you for BEST-CLI and for being with us at this meeting.
You're very welcome. My honor.